Thank you very much, Nazan, Ibru, and your team for the invitation. It's a really honor to be speaking to you. I always admire what the work you do in Turkey on this particular matter, and I think we and I've learned a lot from the work you guys do as well. So that's right. I just want to check, is my screen visible, and can you hear me fine?
Yes.
Okay, great. So I'm going to just give you an overview on home ventilation, particularly invasive ventilation, and some just share with you some of the history and the experience we faced in providing this service, which in Africa is, I think, we're the only center who can actually do it, and because there are real challenges, and I hope that by sharing some of the challenges, experiences, and maybe people may find it useful if you're faced with similar circumstances. So this is not going to be um, um, uh, um, uh, just give you an insight of how to do things differently. So, so first of all, we have to ask, why home-based care or ventilation? I think is a necessity
Excuse me,
worldwide.
we couldn't see your slides now.
Oh,
Maybe you can share again.
let me try again. Sorry about that. Or
Yes.
now, all good?
Yes, it's okay now. Thank you.
All right. I'm sorry about that. I don't know what happened. So I was saying the need for home ventilation is obvious. I think I don't need to, there's no debate about that. Because children, especially with pervasive ventilation, occupy precious high ICU beds in hospitals, which is often how a home ventilation program starts. Being at home is much more hazardous for the patient than in hospital. There's more improved quality of life if you can get the children home to be with a family. There's improved outcomes, and more increased children are increasing in numbers are surviving ICU with becoming technology dependent. And the technology is fortunately improving and making it easier. So we've come a long way with long-term home ventilation, which started really in the 1950s with the polio epidemic, and there were many hundreds of children living in the iron lung, as seen in this picture. But there are real challenges, even though with the new advances in technology and expertise, training and expertise in home ventilation is certainly limited. ICU space is particularly limited. Trying to advocate for funding and money for home ventilation when you've got many other public health and health priorities, competing priorities, is difficult. We've got insurance companies that don't understand the benefits and sometimes won't reimburse or pay for the equipment. I think what's very important, different and I don't know what is in Turkey, but certainly in my country, there's no such thing as home-based nursing care. So, or who to this level. So, the family and parents are required to take full responsibility for providing this care at home. And of course, there are many underlying socioeconomic hardships and living conditions. And this is, for example, this is a picture of like in outside Cape Town, where I say in an informal settlement, which is very impoverished conditions. And you can see as you're trying to send a child home in ventilation in such circumstances can be very difficult. But nonetheless, I think what's important to realize, and the lessons we've learned, is there are some perceived challenges that doctors, health professionals believe might be barriers, and we've learned in our experience that they in fact are not. One important thing is lack of parental education is by far not at all a barrier. In fact, I find it personally the opposite. The more educated the parents, the more problems you encounter with families. Poverty, although people may be poor, it doesn't mean they can't take care of a child. the housing may not be optimal. And here you see these pictures as my colleague and I would go on home visits to investigate home circumstances while we're considering sending someone home. And this is not an unusual for communities in South Africa living in these sort of informal kind of housing that may not have toilets or running water. And you have to bring sophisticated technology into these places. Further, perceived challenges, and I say perceived, I mean parents or other colleagues, doctors will see it as a challenge, but in my view, it's not. Tracheostomies are scary things for many doctors and even parents, and they often it's thought of as only the final last resort when and I don't think it should, that it may be painful and disfiguring, which we know it's not. You need a highly specialized care to look after it, and that's definitely not true. And so these are some of the challenges you have to overcome and perceptions, both in families and doctors. And it certainly improves quality of life. I've just shared these interesting photos. These are in Cape Town. Before my time, my predecessors, the first child sent home on a ventilator was 1992. And you can see some of these are the early pictures. Children lived in hospital, and for many years, months and years. And there were creative ways to get the children to go out to the beach for a walk in the park, and so forth. And these were the very first. One of the first cases was sent home. And this picture here is a family who lived in a very far remote rural farming area. This young man had Pompey's disease. It took 4 years to raise equipment for him, and this was the very first patient sent home. And in this farming community, there was no electricity. The family would occasionally bag him. They had manual bagger when he was feeling breathless. He eventually died, but he lived a good 2 years at home with his family to make it possible. But in order to be able to successfully discharge home, there are some requirements. And these, of course, the standards of these requirements will, I think, vary a lot from country to country, depending on the resources and what you have available. So it definitely has advantage to have multidisciplinary teams looking after these children. You need buy-in from healthcare funders and the hospitals. We have to adopt a family-centered approach. And one of the things that for our program we really insist is from the word go, is that a caregiver who's going to be the primary caregiver would be at the bedside with the patient as long or as much as possible right from the beginning. We have to provide basic equipment like tracheostomy tubes, suction catheters, humidification devices. We need funding, and you really do need, ideally, have a team that looks after them is available 24 hours. So I'm going to just share some of the principles that for our program, which has made it feasible in these challenging circumstances. Number one is to have the family and carers involved right from the beginning, even in the ICU. Starts in ICU, so the child and the family in the center, and it's really important to identify who those key people are right at the beginning and include them in the child's care right from day one. And that includes washing the child, feeding the child, cleaning the child, and then eventually changing the tracheostomy tube. And getting the family involved is important. I think that's the first principle. The second principle, and because of the lack of home-based caring or professional care, which I think is actually in some ways an advantage, you have to, us as doctors, health professionals, we really do need to recognize that families, no matter what their circumstances, do have capacity and commitment to care for their children, despite being maybe dependent on sophisticated technology. And it's very rare that we're unable to educate, teach, and train even the most people who are living in very challenging circumstances to not be able to take care of their children. The next basic three is have simple tools. We've adopted an approach where we use uncuffed tracheostomies for the majority of small children. Sometimes in older children, they have to use cuffed and simple tools. If they have a tape for tying the technology for the tracheostomy care, they come with a pack. They have a simple package with scissors to cut the tape. Suctioning devices, we use a simple technique where you cut the tube to the length of the tracheostomy, the correct tube, to shorten it to avoid any suction trauma. We use many our patients don't have electricity, so we have to have manual or foot pump suction devices, which some people even prefer above electric devices. And then the important principle we changed for all our tracheostomy cares is you can see that we provide a basic kit how to change the tracheostomy, which includes a toothbrush, a pipe cleaner, scissors, tape, and certain positioning the child in the correct position, or slightly extended. And we train our mother caregivers to change the tracheostomy every single day, and to clean it both on the outside, scrub it, and outside the inside every day to use interchangeably on alternate days. And this is important, and this has been it was a real game changer in that since this practice was adopted, we rarely ever have blocked tracheostomy tubes or serious infections, sudden deaths or occlusions, and the parents and caregivers become very capable and confident with changing the tracheostomy, and especially, and that's really important in the face of an emergency, so they could do it any time. And then I think there's some evidence behind this practice in that we know that tracheostomy tubes accumulate very quickly, form biofilm, and this is just an interesting study. They looked at the biofilm stains in bacteria in cross section. They took a tracheostomy tube, and you can see accumulation of a whole host of bacteria, both dead and alive, that tube if you don't change it every day and clean it. And then, of course, we teach them basic emergency ABCs, emergency care, and they must be trained and capable of initiating CPR if necessary. But that's the easy part. Sending children home on the ventilator also is very much dependent on the home circumstances. And we use very basic equipment. I think you may be familiar. I mean, depending on we often use we have a small range of ventilators which are small, portable, not sophisticated, and with humidification. These are sort of in-house made. We had designed them with a thermostat there to regulate a simple tubing. But these days, more and more, we're using the commercially available ones. And I think some other essential requirements, and one of the key ones, and I think this is still a major challenge for us, if there's no reliable electricity in the household, that's just simply not possible. We had an experience here in South Africa. In the last couple of years, made rolling power blackouts, shortages, which was causing chaos in the home ventilation community. So we've had to adapt by ensuring, procuring very quite expensive rechargeable backup battery and power devices, which for cases where there were power cuts. But without electricity, it's a mere impossibility. And that's probably the biggest barrier that we might encounter. And people must be able to be contactable by phone. Most patients in our setting communicate via WhatsApp, which makes it easier. And they have to be in touch with the local emergency services and hospital if that's appropriate. Sometimes we're dealing with palliative situations, and sending them home is more for palliation. And then we try to involve as much as possible our palliative care team to coordinate that. Another useful tool is we've developed a very simple little manual with illustrations for the parents, the caregiver, while they're sitting hours at the bedside learning, but also they can read. And it's a very simplified tool that provides basic care on trachea and on ventilators as well. So I think in this table, what I wanted to illustrate, well, how do we screen who gets home ventilation? The usual, these days we are fortunate. We have been doing we have access to polysomnography, which we do, but quite limited. Not everyone. We've only have limited supply, so we're quite selective who we choose. But it's reserved for really those with neuromuscular conditions and other complicated causes, sleep disordered breathing, where we can need to measure CO2 as well. But in the absence, this is actually not widely available in many parts of our country and other low middle income countries. And we've in this table from the publication we did from our group, we just shared some ideas on how you would, in the absence of polysomnography, what could you do? Obviously rely heavily on your clinical indications and signs and underlying risks. If you look for signs of upper airway obstruction, the use of cell phones, and it's been very, very helpful in our setting to diagnose obstructive sleep apnea. With most patients, even from the poorest communities, have a smartphone these days. So it's become increasingly a useful tool. Overnight oximetry is a good screening tool, but of course it has its limitations, especially when you're needing to, it doesn't enable to separate central from obstructive sleep apnea. But one can use simple things like measuring your blood gas for signs of chronic hyperventilation. And of course, there may be symptoms when you're dealing with hyperventilation. We know the patients who are at risk, and if they have symptoms, lung function, and it would be useful in absence. But ideally, one should have a polysomnography in this group, especially. This is just an example of overnight oximetry, which you can see there with several prolonged clusters of desaturation. And this was a patient with rigid spine syndrome, muscular dystrophy, had severe episodes of hyperventilation, and was started on non-invasive ventilation. So I just want to mention that nothing is impossible, and when families are given empowered to take ownership of the process, the equipment, they become very creative and innovative in how they provide quality of life for their children. These are children, and some of my patients before this kid, he had a SMART syndrome, very 24-hour dependent on ventilation, and his parents, his family made sure that he could participate in marathons by constructing. This young boy loved swimming. He had nemolymodulopathy with severe kyphoscoliosis, and he was not going to give up his swimming, and the family designed ways to block his trachea, and there he is swimming with his ventilator ongoing. So when families are empowered to find the solutions, they do. But of course, we face many ethical dilemmas as well. When you have limited resources, we face a situation where there's no electricity. What do you do? We can't. It is sometimes very hard decisions need to be made, and sometimes it raises a question: who decides what is acceptable quality of life? Is it the doctors? Is it the family? Is it the Ministry of Health? And this is and it's really difficult. We have very difficult ethical decisions to make, which are often determined by not so much by the underlying health condition, but often socioeconomic situations, which is simply not would not be sustainable for long-term health ventilation. And even this was a famous case a few years ago. I don't remember where in the UK where Charlie Gard, a baby with a lethal, can't remember the diagnosis. The Pope and even Donald Trump got involved in trying to when the National Health Service didn't want to, doctors just didn't want to prolong life. So in conclusion, I'd like to just say that home care is the best technology. It's best for technology-dependent children. Tracheostomy care is safe and life-saving, and provided appropriate care and training is provided. We empowering the family, not health professionals, to care for ventilators is actually the best technology and safest. And we have to deal with the complex ethical decisions and be prepared for them. And these are not decisions that are easy to make on your own. So I just want to end off by acknowledging my predecessors who were the pioneers in home ventilation at my hospital in my country, and for many of the practices we do today was established by them. Max Klein, who has passed away, Jane Booth, who's retired, but has been a huge mentor. And of course the moms who are we call them super moms. And Max Klein said the most sophisticated technology is mother. And I think that's a motto we should keep in mind. And the mothers can do a lot without us interfering. So thank you very much, everyone. I hope, I don't know if I can take any questions.